This is Susie Penman on April 8th, 2025 in Brunswick, New Jersey at the Rutgers Global...
New Brunswick.
As I said it, I thought, nope, that's not right. New Brunswick.
Brunswick's probably over in England somewhere.
This is the newer version of Brunswick, New Jersey at the Rutgers Global Health Institute conducting an interview for the Global Oral History of PEPFAR project. So to begin, could you start off by introducing yourself and just telling me who you are?
I'm Richard Marlink. I go by Rick. Right now, I'm the director of Rutgers Global Health Institute. I'm an oncologist by training and been involved in basically public health in Africa for 40 years. We calculated the years this morning. 40
years, wow. And just to give us a little bit of background, can you tell me where you grew up? Where's your family from?
Those are important questions. I grew up, I guess, in the Rocky Mountain area. I say I'm from New Mexico, although I wasn't born there. That's, I guess, where my heart is. And my family's what's living of my family is in Colorado and Texas and New Mexico.
Okay. And what led you to medicine? You went to Brown for undergrad?
Yeah, yeah. I guess two people are role models when you're small. My grandmother was a nurse and probably the sweetest person on the planet, and a great nurse. And had a great uncle who lived in Jordan, Montana, a little teeny town near Fort Peck Reservoir. He was the only physician in the county for many, many decades. Kept trying to get other physicians to come join him, and they couldn't handle, I think, the being in a small town in eastern Montana, not the pretty part of Montana. And the work schedule being on call all the time because you're the only person there. But when I visited him when I was in fourth grade one summer, I was just amazed by what he could do. He delivered babies, went out to the highway if there's an automobile accident, patched people up, fixed your eyes. Was the family doctor for the entire community. And I thought that seems pretty cool. He had the power to help, and he could do all these different things. And so I think both of them probably led me to. I decided early on that's what I was going to do, and then I went on to convince most of my friends that they should do that too.
So you came back to New Mexico for your MD, is that correct? University of New Mexico. Okay.
Yeah.
And when you were there, what led you towards public health when you were in medical school?
Well, the medical school there is very focused on primary care. I mean, the state helped pay for it, like most state medical schools, and it's trying to create doctors to practice in New Mexico, especially rural New Mexico or on the reservations. And so I liked that part of it, but I guess that was also what led me to after medical school, to my internship in New York City, which doesn't seem like rural New Mexico, but it was a internal medicine residency that was called primary care internal medicine residency. Had an extra 4-year internal medicine residency created by this guy named Phil Brickner, who basically did house calls all over New York City. We were especially up in Harlem, where you were yesterday. We were in vans coming up from Greenwich Village. I was at St. Vincent's Hospital in Greenwich Village, and doing house calls or whoever needed it. And so it was just like the coolest thing to be basically doing primary care medicine, but in Manhattan and in Harlem and other places of need. So that was sort of, again, answered that call of primary care medicine is pretty cool. And every patient was different, you know, their needs were different each time. You know, unfortunately, that was my fourth year. I spent a lot of time in New York, and then my internship was 1980, 81. I say unfortunately because that's when AIDS got started, and that was one of the epicenters, the Village in New York. We didn't know what was happening, and my friends who were other physicians or nurses there probably gravitated towards St. Vincent's in the Village because they were gay, and they also, just like our patients, were getting infected with this new virus. You know, it was, I thought, coming from New Mexico, I'm in the big city, we're seeing these weird cases. I thought I must not have studied very well, or must have gone to a backwards medical school, because we didn't learn about cryptococcal meningitis or miliary tuberculosis. That's where tuberculosis is just spread all over your body at the same time. And we didn't know it at the time, but those were the sort of end stage opportunistic infections of AIDS. But our patients had the infections we didn't know that was really from the underlying immunodeficiency. So the internship became quite dramatic, not just as an intern in the middle of Manhattan, of a very busy hospital where we took pride in our emergencies and keeping people alive, but we were in the middle of this pandemic that we didn't know it was going to be a pandemic, but in the middle of this new epidemic. We were calling it the gay bowel syndrome, because there's a lot of GI problems. So St. Vincent's, which was very attuned to gay health, was where a lot of the gay men came. And so as outpatients, we were seeing problems that no one else was seeing in the country, because we were sort of concentrated there, and we didn't realize again that it was from this viral infection. I went back to New Mexico after my internship I thought it'd be good to live with my wife, and she was a medical student there, and so finished out my residency there, but chose to come back to Boston, looking at eventually going into oncology. But I knew Boston had a lot of oncology training programs, so I thought I could find something as I took care of my first son for a year and a half at home in Boston, and looked around for oncology training, which to me is like a specialist doctor, but you're still a primary care doctor, because you become the patient's primary doctor if they have cancer, and they have other problems too. So you really got to be both the primary care and the specialist. So I went into oncology in Boston, in a Harvard program, after staying home with my son for a year and a half. I'm only smiling because it was hard to get back into programs, because the directors of these programs in Boston would literally say, "Oh, you're not a serious person, you're not serious. What have you been doing?" So one place that interviewed me, two of the people that were interviewing me on the different, appointments, they had their kids in their office, one in a bassinet and one a little toddler. So I thought, okay, they're going to be family friendly here. And so it was kind of the edge of Harvard academia in terms of training programs, but it became more mainstream, especially as it became the AIDS hospital for Boston, and no other hospitals would admit AIDS patients. So my oncology fellowship basically became an AIDS fellowship, which I wanted. AIDS patients have certain cancers they have a propensity to get, but also it was a new, interesting but terrible disease, and it sort of fit, I think, oncologists dealing with tough, deadly diseases, and also being primary care doctors or nurses at the same time. So my oncology fellowship really became an AIDS fellowship.
And you helped establish the city's first clinic for HIV.
Yeah, I was the oncology fellow, and we had an ID fellow for infectious disease, and the two of us were sort of told that what do you guys want to do? Well, we need a place to see patients. And we can admit them to the hospital, yes, but we need an outpatient place because to see them. So we set up the first clinic. He is the ID fellow, and I was the oncology fellow for the clinic. And we, the oncology nurses were the only places I had were an oncology clinic for outpatient chemo. And the oncology nurses, probably rightfully so, were a bit nervous, not knowing. We didn't know the origins of this, really. It was we're just discovering it was a virus about then. And were there patients that were being treated there for cancer, were they going to be susceptible to this new infection? So they gave us a little utility closet to set up, an exam table. And you had to keep the door open to have the table open up all the way to examine somebody that was lying down. But literally in a utility closet. And I can't tell you how many gay men, who were most of our patients, would keep saying, "Doc, I thought I got out of the closet, and now you're putting me back in." And but we heard that joke a few times. But it was literally the only space that we were allowed to have, for the first year.
Yeah. And so what was that, 1984?
Yeah.
Okay.
Yeah.
And so in 1985, was that when you were working with a team of doctors? Were you in Senegal, a team of researchers that discovered and studied HIV too? Was that when you were still based at Harvard?
Yeah. So on your fellowships, usually towards the end is where you have more time, where they block off if you want to do research or something. You've done your clinical required time to get certified or to get your, sit for the boards and whatnot. And usually that takes about 2 years. So on your third year, you can keep going after that, but in your third year, I had pretty much a year that they said, well, you can do research. And I was realizing at the time, I didn't really understand the literature. People were learning new things in molecular biology. Now we'd call it other things, but back then it was the general term molecular biology. Basically, starting to look at genetics and diagnostics that didn't exist, but were starting to be used, looking at these new viruses. And I realized I should spend a year in the lab. And my director at the time, Jerry Groupman, who was a well-known AIDS clinician and ran my fellowship, and he said, "I know this guy down at the other end of Harvard, at the Harvard School of Public Health, Max Essex, who had access to the virus. The virus was really hard to get a hold of at the time because it had just been discovered, and you had to be in the U.S., you had to be friends of Bob Gallo before you got the virus. And he didn't give it to people that weren't his friends, which he ended up making a lot of enemies because of that. But we had the virus at our hospital because Jerry Groupman was friends with Max Essex and could get the virus from him. But Max was really the virologist. He's a veterinary virologist who came up with the first theory that, this AIDS in humans is just like what we have in animals, in many mammals. Cats, other mammals have retroviruses, the class of virus that AIDS is. And so he said this AIDS must be caused by a retrovirus, a human retrovirus that we haven't discovered yet. He was right. So I was the physician and the inexperienced lab person in this really cutting edge veterinary lab, that was studying animal viruses, but now was studying human virus, the AIDS virus. So I learned how to, which most people didn't know, how to grow these viruses at the beginning and how to concentrate them so that you could study them with your molecular tools. So I was just learning all these techniques that other people didn't know yet. And then when we found some collaborators, French and Senegalese collaborators, the Senegalese collaborator, Suleiman and Boop, who was a microbiologist in Dakar, Senegal, brought over blood samples from sex workers from Dakar. And he thought, I'm going to one of the premier AIDS labs in the world. I collaborate with the French who all work with Max Essex. Let's see if the AIDS virus is in Senegal. So there were 300 samples from sex workers in Dakar, and we ran them to both the AIDS virus. We ran them in the lab to see, does this look like this blood has antibodies to the AIDS virus? So has it been exposed to the AIDS virus? A person would be infected with the virus. And we saw that the women certainly were infected with an AIDS-like virus, but it was a monkey virus that had the AIDS monkey virus. Our AIDS virus that comes in humans is an ape AIDS virus. It came from apes. And so our lab was discovering monkey viruses in Africa. We're looking for the origins of this AIDS virus and looking into all different primates and different things around Africa. So the women looked like they're infected with the monkey virus, not the AIDS virus. They're closely related, but you can, long story short, we didn't quite believe it. And the Senegalese, Suleiman and his team, some of which were clinicians, said, no, we call them, I said, are these from women, right? These are from people. Yes. The S stands for sex worker, not singe, not French for monkey. We thought the S must be French for monkey. These are monkey samples. But no, they're sex workers, and they're working women. They're healthy as we can tell. They might have other problems, but they don't have AIDS. And the group said, how do we know? Nobody's going to believe that 300 people with this AIDS virus would not be sick. Suddenly I had a purpose in the lab because I was a doctor that saw a lot of AIDS patients, and I raised my hand and said, I can tell you whether they have AIDS or not just by talking to them, or whether they have immunodeficiency, the beginnings of AIDS. And if I can examine them, I can certainly tell you. And so literally 2 weeks later, I was in Senegal. So that's got me to Senegal, and I kind of never came back, in terms of what we did there with our Senegalese collaborators and our French collaborators. But really, it's interesting, I hadn't thought of it this way, but back to the primary care part, the Senegalese approached prostitution in a very, I'd call it enlightened. They're an enlightened Muslim country, so they're saying prostitution, we don't condone it, but we're not going to blame the prostitute, and we're not going to make it. If we can keep people healthy and actually treat their sexually transmitted diseases and treat other problems, and not put them in jail, they won't go underground. We really want to pursue the Johns or the money makers in this situation. So they made prostitution not legal, but if you were registered in their public health clinics, and you register, I'm a sex worker, and here's my picture, my ID, and my stamp that I've attended the clinic. If you got arrested for prostitution but showed that to the police, they'd let you off with a much less of a penalty, or just a warning. If they kept seeing you, they had to actually probably detain you for a few hours. Now, if you weren't registered, you'd spend the night in jail. So it was they wanted a deterrent, but they wanted to get people to register, and so they could stay as healthy as they could. They didn't know they had AIDS They didn't have AIDS in the population at the time. They had this second, a monkey virus, which wasn't causing AIDS, but they were treating syphilis, gonorrhea, the other treatable sexually transmitted diseases, and also trying to keep the women off the streets and not needing to be prostitutes. So the clinic was open to their families, the women's families, and their kids, whoever needed treatment. So they were almost like a social program for prostitutes. Then we came to start to look at, well, what do you need? And we realized, well, no, here's all the three. You want to see any of those 300 women? And here they all are. And here's a clinic where we have them and their families. Anybody's being seen for free, with the Senegalese government paying for it. And so to a researcher that's studying a new human AIDS virus, and all the subjects are already registered and they're with pictures and IDs, they're already in a clinic, that was golden. And so we were able to show, unfortunately, the original AIDS virus, which you call HIV-1, came into Senegal a year or two after that. So we were able to, unfortunately, have both viruses side by side and show definitively that the second one, HIV-2, the monkey virus, was not causing AIDS. It did so rarely, but really dramatically less than HIV-1, the one that then came into the country, just like it came into all countries around the world.
And I'm thinking too right now of that it seems radical approach to dealing with sex workers.
Mm-hmm.
And you're a young doctor who's just come from the States. How did that approach to that population inform you as a doctor going forward? Did it? I imagine it made a pretty strong impression.
Yeah, I think that's why I think the word enlightened is a good. It was a public health approach. They're trying to what was best for the population, and especially the women, but their families, people that might get exposed through sex to the women. Would be best to actually have things out in the open in a clinic where people can talk freely, get treatment. So that's kind of an enlightened public health approach. I guess that sort of showed you the power of public health, or that approach. I wasn't trained in that public health. In fact, I've never gotten a public health degree, even though I was a professor of public health at Harvard. But that's another story. But I guess that was the introduction to public health. That it really matters. Policies really matter, and programs really matter that are set up in that enlightened way.
Mm-hmm. And from Dakar, you came back to the States, and then what led you to your work in Botswana?
Oh boy, a lot of things in between, I guess. But we collaborated intensely for 15 years with Dakar and Senegal, and I'm still. Tomorrow I have a working group collaboration with the same group, and Rutgers, we're trying to get involved in Senegal. So Professor Mboop, his youngest son, is my godson. I mean, so we're really like family, literally in many ways. Our group from the Harvard School of Public Health with Max, Phyllis Conkey, others that we're all in the lab together. There's only like a few of us, but really worked closely together with our French colleagues and the Senegalese group. We ended up, our lab at Harvard became the place to do training. So a lot of African scientists came, learning again how to grow this virus, how to study it, but then they could take it back to wherever they were from, or go on in their career. So we had different collaborations in the former Zaire. Worked with Oscar Kashala, who was, we looked at HTLV1, another retrovirus that causes, associated with T-cell leukemia and lymphoma. We found that higher in leprosy patients for some reason, and there's a leper colony near Kinshasa. And we worked in, then over in Tanzania, there's other colleagues from Harvard that worked a lot that sort of took off on that partnership, which is Wafai Fauzi and Tanzanian colleagues. So it was really across what we'd call, I guess, back then, the AIDS belt from Central to East Africa. And we thought that was, it was at the time, where the numbers were the worst. 5 to 6% of women giving birth would have the AIDS virus, and they can pass that on to their children, obviously. Then Max Essex and I saw this graph from the WHO, and our friend was running the UN AIDS, UN Agency for AIDS, Peter Piot, at the time, and the graph showed the leveling off of women delivering babies. The prevalence over the past few years was leveling off. So the WHO was, and UNAIDS was showing that as good news, meaning it's not just continuing to rise along the AIDS belt. So it was leveling off at 5 to 6% of women delivering would have the AIDS virus. And in their good news, they had one line that went down from 0, like in 1990, up to 50%. These are women delivering, and 50% exposure or having the AIDS virus. And the line said, Mola Pololi, Botswana, on the line. And Max and I we've been working in Africa for 20 years or more, and we both looked at each other and said, where is Botswana? And because we were obviously working more in Central, East, and then West Africa and Senegal and around Senegal. So I'll tell you why most people don't know where Botswana was at the time, but we ended up, we had a friend that was helping us. He's in the diamond cartel, I guess you'd say, legal cartel, with the De Beers cartel, and Maurice Templesman, who he pretty much knew every president in Africa because of his business of dealing in rough diamonds and then figuring out how to get them to market. So he's not mining, but he's everything after mining, I guess. And he helped us get started in Senegal. He said, we found this virus, or in the lab. We'd never been to Senegal. We had the Suleiman Mboop who brought the samples over, but again, we're just getting started in Senegal. And Maurice is the type of person who said, "Oh, you're in Senegal? do you want to meet the president? So when we started telling him about this curve we saw for Botswana, we called up Peter Piot first and said, is this real? It's 50% pregnant women infected. And, it's usually 5 or 6% in the worst parts of Africa for infection. And we said, and Peter said, no, I checked with my epidemiologist, and it's not just 4 samples and 2 of them happen to be positive for the AIDS virus. No, it's a real survey, and it's 2 surveys actually, and a year apart or something. And so we can't explain it, but nobody really was aware or thinking about AIDS in the southern African part of Africa, in southern Africa, because if you remember, South Africa was really banned and boycotted, and with apartheid, it was really not part of the world community economically, and also, like most places, they said, well, we don't have an AIDS problem. That's up there, up in the other part of Africa, not down here in South Africa. And just like syphilis used to be called by the Spanish the French disease, and by the French it's called the Spanish disease. We don't have it, but they have it over there. And so just like syphilis, I think people would do that with their nationality with the AIDS virus. So people weren't looking in Southern Africa. And if they were going to be talking about it in policy-wise in the government halls of government, they just say, we don't need to test for it. We don't have AIDS here. That's in the, the bad part of Africa or something, or that's somewhere else. Well, it turns out it was growing or spreading right under everyone's noses. And Botswana ended up having the worst prevalence in the world. That's because those numbers were real, but also the whole region had similar numbers. So it wasn't something unique to Botswana. And so basically, again, Maurice Templesman says, I'm having the president of Botswana over to my house. Every September there's the UN General Assembly. He lives in Manhattan, and he usually entertains the different African presidents that he knows for his business. And Botswana is one of the biggest diamond producing places in the world. So he said, actually, Molopololi, I have a diamond cutting factory in Molopololi. So, stroke of luck, I guess, or whatever. But Max met with the president of Botswana literally the next week in New York, President Masiri. And President Masiri told him, please come to Botswana yesterday. It's real what's happening. We didn't know it either, but we're having people now starting to die, and we really need help. And we believe it's real. So again, we were off to Botswana pretty much the next week after that, seeing people getting blood samples, figuring out, the Maurice's diamond cutting factory. He asked his head of HR for the factory of human resources, these 2 guys, Americans, are coming. Can you drive them around? They've never been to Botswana, and they need to go see the Ministry of Health. They need to go over to the TB clinic. They want to go see the hospital. They want to talk to so-and-so. And just show them the people that they need to talk to. Don't worry. She's worried, like, I'm busy. I'm running this diamond cutting factory. And he said, don't worry. They're Americans. They won't be back after this. But we kind of never left Botswana after that. And that woman that ran HR is the chief operating officer for the main Botswana-Harvard partnership there for now retiring, but she'd been doing that for 20 years. And so we created a partnership in Botswana that continues on now. independent from Harvard, although we even took Harvard out of the name, not on purpose, but just because it's broader than HIV and it's broader than Harvard. It's dealing with health problems for the country. It's the country itself. The next president after President Masiri, President Mohai, who you should really talk to. He is really one of the, unfortunately President Masiri's passed away, but President Mohai is really one of the heroes of AIDS. And he took over, or he was elected as a president, and he said from the beginning, I will never give a speech on any topic that I don't also talk about AIDS and how to deal with it in our country. The other thing he's well known for saying is that if we don't deal with this aggressively, we will become extinct as a country and as a people. And again, with half the women delivering babies having the AIDS virus, and 1 out of every 4 people walking down the street has the AIDS virus, he was correct. And so we went to Botswana, I guess with a very motivated partner, the president and the leadership of the country and everyone. Every family has been affected there, and people, this was before there was effective treatment, so people were just bringing their relatives in stretchers to the laboratory door. And we realized, we got to find more space, we need more clinic space, we need a lot. I thought one of the best stories around needing more space and what was happening, we said to the president, President Mohai, we're going to need more space. People are bringing patients in. We only had this little lab space, about the size of this library, and a couple little offices. And he said, I'll send my planners over. You tell us how much space you need. And oh, great. And so we brought over our main laboratory scientists, Tun-Ho Lee, Max, and I met with the government planners. We talked to them and we told them what we needed, and they said, okay, we'll be back, and give us a week. They came back in a week, and they had all these blueprints, and they rolled them out on the big table. We thought, wow, look at this. And he said, yeah, we thought, they actually did consulted. I mean, these were real planners, and these are people that built stuff, and they built things for the government. But they said, well, we thought you need this much lab space, you're going to need this offices and everything. Yes, this is fantastic. So it looked like on this layout of the first layout, it looked like we'd have, 5 times the amount of space that we had. And we had space. We could also, he said, we're going to need clinics, so we'll do it right here on the hospital grounds, and we'll figure out clinic space. Can you train everybody, both the laboratory and the clinic? I said, yeah, we can do that. We'll help with that, but we need the space. And so we thought the meeting was over with. And they said, wait, that's just the first floor. So they had 4 floors. And they built the BL3, Biolevel Containment 3 levels laboratory space, more containment space for the viruses, for dangerous viruses than we had back in Boston. And they built it all. Max actually took a year and did a sabbatical over there just to watch this building being built and help, figure out what was going on. And on World AIDS Day, when it was done, President Mohai handed over the keys. We had this little ceremony at the front door, handed over the keys, and we all shook hands. And what we were very proud of, no one ever talked to any Harvard lawyers or government of Botswana lawyers. No one signed any pieces of paper. It was a handshake that said, here's the lab. And it was this huge building that's there still on the campus of the main Princess Marina Hospital, the main, referral hospital. So, we finally figured out we're going to have to work out some things. Who's going to take care of security? Who's paying for the lights? Who's doing repairs? But we worked all that out just, again, verbally. And, only now the government of Botswana and the Ministry of Health kind of saying, wait a minute, what's the future of this? It's been going on for 20 years. We better codify this and write some agreements out. So they're working out what's going to happen going forward. But it's was really a partnership, like in Senegal, one on trust and friendship and having a common goal and sort of dividing the labor. You do this, we'll do that. You do that, we'll do this. And so President Mohi is really one of the heroes in the response to AIDS and led the example for other African countries how to deal with it.
And this was around, you said it 25 years ago. This is in 2000-ish, is that correct? When they handed you the keys on World AIDS Day. What year was it? It doesn't have to be exact.
I think it's 1998.
Okay.
But I think of 2000 by the AIDS meetings. We used to have these, still do, but these international AIDS meetings. They marked the year. And the year 2000 was in Durban, so it was the first AIDS meeting, international AIDS meeting in Africa, and everybody sort of landmarks that. It's the first meeting that Tony Fauci went and saw AIDS in Africa, and he says it sort of opened his eyes. He didn't realize what was going on until that meeting and that year. And we brought a lot of people over that year. So a lot of things were already built in Botswana. The thing about Botswana, we went ahead. The U.S. government wasn't doing a lot on AIDS, wasn't domestically, and certainly wasn't doing almost anything internationally. We actually brought partners that would do something, would bring money and would bring expertise to partner with the government of Botswana. And just got started a few years before PEPFAR.
Right. Yeah. I mean, we want to get to PEPFAR, but you did so much work beforehand. You founded the Kitso AIDS training program, which became Botswana's national AIDS training program. I'd love to hear a little bit just about that before we get to the launch of PEPFAR and how that affected your work.
Okay.
We have so many things we could talk about, I know.
Yeah. I guess my wife warns me, don't drag on the story and make it too long, and so I'll try to not drag things on. But I think one interesting story of how that happened was, so I'm at Harvard School of Public Health, as I said, an MD in a non-MD lab, doing our lab work. And the dean at the time, Harvey Feinberg, called up and said, we need, we're going to bring any of the faculty that are working on AIDS, which there's several big names at Harvard. At the time, we're going to have a meeting with a private meeting with a big executive from Merck, the drug company. And, okay. Why? Well, they want to know how to get involved in AIDS. Oh, okay. So people show up for that meeting, and so only the heads of different AIDS efforts. So there was Max Essex, running his lab, was really interested in finding a vaccine for AIDS. So in the veterinary world, you have a vaccine against the feline leukemia virus, the feline AIDS virus. And, you can, if you have cats, you probably have a vaccinated cat. So Max was also thinking, geez, we should be able to make a vaccine against this human retrovirus. We got vaccines for the animal retroviruses, same family. So we're trying to make a vaccine and test the vaccine in Thailand and other places. And other political scientists, Michael Reich, Robert Reich's brother, he had a software program that helped governments figure out policies, whether best policies for AIDS, and taking economics and everything into account. And if you used his software, you could work with governments to figure out their best policies. Others had Health and Human Rights were another group. Jonathan Mann was at Harvard with us at Harvard School of Public Health. And anyway, long story short, all the AIDS people were around, and I went to the meeting with Max. But this guy, Henry Lipmanowitz was newly in charge of Merck worldwide, and Merck had changed. Instead of being organized according to North and South, like North America and South America are together, they changed their organization. They became marketing around the world. So Henry realized, Africa's and India, all these are in my area where I'm supposed to be thinking about Merck products and marketing Merck products. And then he realizes Merck has a pipeline of new drugs that are coming out. Nobody knew how good they were going to be, but we're going to have the new drugs that are probably going to look like they're going to be very good, the protease inhibitors. We're going to have one coming out, and we're going to have products that people need worldwide, but they're not going to be able to pay for the prices that we're going to probably be charging. So he sort of said, we need to be involved in the solution worldwide somehow, not just about our products, but we need to be involved in the solution. We need to be involved in AIDS. We're going to looks like our company is going to become one of the AIDS companies making products. Again, this is only in retrospect. He's not saying this because he's not talking about the products that are secret at the time, probably, or partially secret. But he did say, he wants the company to be involved, and he wanted to give a big grant of $1 million a year, which was a big grant back then, the biggest that Merck had ever given in their foundation, to some solution, and he wanted to hear everybody's solution. So Max Essex, of course, said, well, the most important thing is to make a vaccine. And if you give me the $1 million a year, we think we can have a vaccine. We're at the cutting edge of that. The political scientist, Michael Rice, said, well, my software is really going to help. And it would, and I can work with governments. That's what I do. And anyway, everybody had their solution. And I just said, I don't know, but I know that I can, if I had some money, I can keep people alive a third longer than if I didn't have anything. And Henry and everybody knew there was no drugs that were keeping people alive. This was 1995 or 94. And he said, well, how do you know that? I said, well, there's a researcher who works in the Northwest United States, all in one HMO, and she studied people who did primary care with AIDS patients. And the more experience you had with AIDS patients, the longer your patients lived without access. There weren't any antiretroviral drugs when she started looking at way back in the early 80s and mid 80s and then late 80s. So she looked at 3 time periods, even when AZT, the first drug, started coming out. She redid the numbers. and she had 3 levels of experience. And experience means you only had 5 patients in your experience, which wasn't much for those of us that ran AIDS clinics, but it just meant some experience with AIDS patients as a primary care physician. Your patients lived a third longer. And this is back when, if you got a diagnosis of AIDS, half were dead within a year. And pretty much most were dead within 2 years. So a third longer was much better than most chemo drugs or chemo things that we were using for cancer patients that had a deadly cancer. So Lipmanowitz, I said, if we could test that you could do set up clinics where people are seen and have the clinicians get experience seeing AIDS patients, because they're going to be in every country. They'll live a third longer, and I can show you that. So this is Kit Tahana, who wrote this in the New England Journal. Then it came out. Again, not that many people to be qualified as an experienced clinician, only 5 under your belt, so to speak. So I was amazed. They asked to meet with me, and I said, "Yeah, why don't we test this in 5 different places all around the world? You're going to be around the world." I knew he was going to need to be marketing and thinking about AIDS, in Southeast Asia, in the Caribbean, in Africa. So, long story short, they gave me the $1 million a year. Max sort of laughed and sort of said, "Okay." Max had a lot of funding for his vaccine and other research. I was part of his group, but I went to start going where my friends were: Senegal, Thailand. I ended up having to figure out South Africa, but had that took a while to figure out that country. But so we set up AIDS care teams called the Enhancing Care Initiative in 5 locations around the world. A couple Merck executives followed me around for 3 years. I figured it out after a while. They weren't just following me around. They were worried, that they had this big Merck grant. And what is this guy going to be saying? Are they wasting their money, or is it really happening? But it worked, and we had teams, again, run by local experts to do local training, bring patients in. Don't be afraid of AIDS patients. People should be cared for, and they can be cared for, and they'll live longer. So that there's a story in each one of those 5 countries. But I told the Merck folks, I said, this is really great. For a little more money, you can add another country on, and a little more money, you could just keep adding. And now the drugs are going to start coming, which Merck was part of, and Bristol Myers Squibb and Glaxo, and it's going to be better and better. You'll have a clinical network and country by country. And they were saying, "Yeah, we don't know if we can keep adding on countries." And I said, "Just come with me to Botswana," because we had already started the Botswana partnership. And we're in South Africa anyway, every other month, to set that up in South Africa and KwaZulu-Natal. Just come with me to Botswana. You can meet everybody in one day. It's a small place. Meet with the president, the minister of health, and you can even go on a little game drive. And then you can stay the night and leave the next morning. So I convinced them to come to Botswana because I wanted it to be the 6th country of the 5 locations. I said this would be easy, and you could add on a little more money and add Botswana in. The Merck, especially one Merck executive, started thinking more about it, and he realized this is not going to work to just keep adding to go to how many countries in the world, but we need to really, with this little bit of money for each country, I mean, $1 million seems like a lot of money, but if you're dividing up among 5 countries, and it's going to be over time. So, long story short, he went back and convinced another Merck executive that they really need to think bigger, and they got the Gates Foundation to start thinking big. This is back when the Gates Foundation did think big, and new and innovative, and you could just talk to a couple of people at the Gates Foundation and they'd make decisions. And so they said, we're going to have a secret meeting at the Gates Foundation, because it's not like the secret meeting we did at Harvard for $1 million. We've got the Gates that want us to give $50 million, and Merck will give $50 million. And by the way, we'll donate our drugs, but don't tell anybody that. And so we really want to make a big commitment to see if money's not the problem, all the other things. Because we always said in each of these 5 countries that we did the initiative in with Merck, so it's not really the money. It's really hard to change health systems and to get enough people. There's not enough doctors and nurses. There's not enough logistics, the supply chain, all the other things. And money's a problem too. So let's get money off the table. And they said, let's pick one place in the world where we'll give all the money to one place. And the government has to really be in, because it's not coming in from the outside, but it's really would be a government public health program. And Merck and Gates will give the money and partner with the government. But the government will decide, whichever government they choose or does this would choose. And so the secret meeting at the Gates Foundation was try to get other partners. So they invited the U.S. government, USAID, CDC. They invited other foundations, a couple of them. None of them were as big as the Gates Foundation, so they kind of intimidated by what would our little foundation, which would be, they're pretty big foundations, but what would ours compared to the Gates Foundation? But we had this meeting, and the meeting was basically like Sophie's Choice to decide where would this 100 million plus free drugs plus the beginnings, of a partnership that could grow, but where would all this money go? Again, in the 1990s, everybody had their, just like at Harvard, everybody had their opinions. U.S. government people thought, well, you should do it in where we work, in Cote d'Ivoire and Uganda. And that's because we can then monitor it and make sure we get the credit for it and do it. And they said, well, no, we're not talking about 2, we're talking about 1. And those are pretty big countries, but the way we do it, part of Uganda or something. So the U.S. government had their opinions of where to do it. The USAID representative thought it was immoral what we were doing, and he pulled out, said, we're not going to be a partner in this. It's the wrong thing. You need to just spread your money and give it to us. We'll spread it for you. So it wasn't I'm not saying he was right or wrong, but he used the word immoral, that this Sophie's Choice was immoral. The other 2 smaller foundations just said, we're not going to play. We're too. You have the Gates Foundation. So long story short, it was just Merck and Gates at the end. And they told me goodbye. We all left the meeting at Seattle, and I didn't hear from them because we didn't know where this was going to be. But they went back to do their corporate calculations, and there's spreadsheets of risk and benefit and blah blah blah. And then I get the call from, again, these Merck executives I've been traveling around for the past 4 years to all these countries with, so I know them pretty well. I get a call from one of them because they were radio silent. I didn't hear from them for several weeks, which was weird. Mm-hmm. Then Guy McDonald, one of the ones, calls me up, and he said, hi, this is Guy. And I said, the country's Botswana, isn't it? He goes, how did you know? How did you know? I said, well, you wouldn't be calling me if it wasn't Botswana, number one. Number two, it's the one that makes sense because it's small enough that you can really see if you want to make a national difference. And it's, 100 million is a lot of money, but it's still, it's not going to go far in Nigeria or Uganda or somewhere. The populations are bigger. And Botswana's organized, wants to partner, has all the things that the elements of success. And if you weren't successful in your pilot program, you're not going to go on, and you would have wasted all the time of everybody. So I knew when he called me, it was going to be Botswana. So that started, to answer your question, I know I'd go on too long. We formed a company in Botswana that had one beneficiary or one customer, which was the government of Botswana. And the company was, there were 5 board members, and there was Merck and Gates and me on the board. So I was the 5th board member, not representing Harvard, just as a person. And I used to laugh at the Merck and the Gates members. I said, you made me the most powerful person on the board, because if you two disagree, I'm the 5th vote. And they'd laugh and they said, no, Rick, you don't understand. We're never going to come to a vote. We're never going to let you decide. But the company went on for 14 years. And Gates sort of pulled out, Merck pulled out responsibly and gave it a year or two ahead of transition time. And the company still exists and still works in Botswana and does AIDS, TB, other things that the government wants to respond to, COVID-19. Mm-hmm. So it really is a sort of an implementer and helps the government respond to health problems, especially infectious disease. But that's where we also sat down then with the Minister of Health at the time, Joy Pumapi, and the other leaders and clinical and government leaders that would be part of the Ministry of Health, and said, okay, we have this money, we have a structure, companies and Gates are going to be happy doing this as long as as long as the government's the sole customer. What do you need done? And Joy Pumapi and the permanent secretary at the time, others said, well, we have 5 things we need like yesterday, which is prevention of mother-to-child transmission. I mean, that's shown it works. We need a program in that. We need more clinic space. This is going to be an outpatient effort. We're going to keep people out of the hospital. We don't have enough clinics. We don't have enough doctors and nurses that know how to use these drugs. We need training. We need the drugs, but actually that wasn't on their list. Botswana's kind of said, we'd rather not be dependent on getting donated drugs. We'd like to chip in and buy as much of the drugs as we can. And after just a few years, they ended up buying all the drugs that they used themselves. And Botswana has some money. So the partnership really identified these 5 areas, and the company, HAP, said, okay, we're on it. We'll report back to you. We created a forum that all the ministers of health, all the ministers, not just health, agriculture, which included cattle and their other big issues, Minister of Finance, all the ministries would meet at first every week, then every month, and meet with HAP, and they say, how are we doing? Well, we need the clinics built over along the border, where truckers are coming on the border. And so they get a hold of the Ministry of Transport. Can we use that parking lot we're going to build a clinic, by the end of the next month, we'd have built a clinic along the border at this station and this station. But you needed all the ministries sort of pulling together, and HAP was sort of the implementer. And back to Kitso, the Kitso AIDS training program, we said, well, we can train people, but let's put that as one of the 5. And so we started it at first with, we had already started a training program because we had clinics at the hospital where our lab was. And so we said, we can just take our training program and expand it to be wherever patients are being treated, because everybody's going to need to know how to deal with AIDS patients. They'll live longer, number one, and everybody's going to need to know they're not infectious. Cleaners are worried about, am I going to get, the cleaners are going to clean the clinic, or am I going to get infected? I mean, this is the beginnings of all the fear and stigma that happens. So everybody got involved in the training program, whether you're a cleaner, whether you're a pharmacist, whether you're a nurse, or whether you're a doctor. And to prescribe drugs in the country, you had to take the basic week-long AIDS training program, or you couldn't prescribe drugs. So they made a national policy that people had to be trained to do this. And we went on to train the nurses how to prescribe. So 80% of prescriptions in Botswana are by nurses. They never see doctors. So they're nurse-led care, which is the way the health system is a lot in Africa, and especially in Botswana and other places. So the nurses really run the show, but also learned how to prescribe and do refills and do follow-ups and patient navigation. And we created a number of different trainings that just kept adding on to the basic training that was required. What we really liked is the neighboring countries, they would post positions, like in Namibia, where I'm going to go next month. They would post positions in their ministry for people to because they were having AIDS, a lot of AIDS patients, and they'd post positions to work in their AIDS clinics, and they'd list at the bottom, Kitso AIDS training preferred. They didn't have the Kitso training, but they were just trying to poach, trained people from there next door. And then we also transferred the Kitso training to Tanzania, where we had the Harvard partnership with PEPFAR, eventually with PEPFAR there, and to Nigeria, where we had a Harvard partnership. So long story short, Kitso got started with that first laboratory and clinic, at Princess Marina Hospital before HAP and all the money came in. But we were just in the position to then train the rest of the country. Not Harvard people per se, but Botswana experts. They became the experts. Marty Hirsch, our main clinician at Harvard, is like the most respected AIDS clinician we had. He came over to Botswana. He says, "Why am I here? People here see more AIDS patients in a day than we see at Mass General, all month, or maybe all year." He'd say, "They're so experienced here." And that's that again. The more experience you have, the longer your patients are the better your patients are gonna do. Yeah. And Marty used to just laugh, saying, "You've got the experts right here. You don't need people from Mass General and others coming over here." So
there are 1,000 questions I could ask, but I do want to get to PEPFAR.
Yeah, okay. PEPFAR would be good.
We've got half an hour.
Uh-oh.
It's also fascinating, and it also really, lays the groundwork, for the PEPFAR funded work that you end up, helping out with. But first of all, can you just tell me, what was it like to find out about PEPFAR? Where were you? That it's a huge announcement that it's like you've been working in this field for so long. You've gotten a lot of funding before, but PEPFAR is in a whole nother scale.
It's the B word, not the M word. The billions rather than millions. Yeah.
Yeah. So do you remember where you were?
Oh yeah.
What you
it's
thought?
Like you remember when 9/11, or you remember certain things where you were. But I remember there was some hint that I should watch the State of the Union address by George Bush, and a couple people that were hinting, I hope you'll be interviewing them, and they were in the U.S. government, but they were hinting you should really watch the State of the Union. And I remember yelling to my wife, Kim, when he announced, the U.S. will be spending $15 billion in specific African and Caribbean countries to partner to help with the scourge, the problem of AIDS. I can't remember the exact words. And I remember just yelling because it was very clear. He said billion. I was just yelling. He said billion, 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 billion. My wife said, "What are you yelling about?" It's just unbelievable. It makes me cry right now just thinking, that sort of, my God, finally, because money is important, and it's how you use it too. But obviously, but that was obviously a game changer. So, when that happened, that was State of the Union, so that's like January. It takes a while because it was very secret. So the actual government wasn't really set up to run a grants program, so it takes a while to get going. So the actual first request for applications, the RFA or whatever, track one, because it was the first one out of the gate, didn't come out until World AIDS Day at the end of the year, December 1st. And I guess symbolically or something, we finally got it out the same year that he had announced it, 12 months earlier, 11 months earlier. But that meant you had to get the grant in by the end of the month because they wanted to make sure it was in that year, calendar year. So by December 31st, again, that's over the holidays. You had to have this huge, they were for, up to $125 million for each grant. And they'd never given out these type of grants. So you're kind of like saying, do we budget for flat funding? Like you start off at this level and go for 5 years at the same level? That's not very realistic. You're going to have to go like this. How do you predict how you're going to do this? And, so everyone was scurrying around trying to figure out this. But the criteria was you had to be an organization that had worked at least 3 years or more in care in a setting overseas, like an African or Caribbean setting, helping with taking care of people and doing clinical work. And you had to be in at least 3 or more places. So that 3 and 3 eliminated sort of, the one-offs, and so because they wanted to get started right out of the boat and have multiple places, because the president had said we're going to do 15 countries and we're going to, get this going. So they wanted ones that were already ready to go and have partnerships. So at Harvard, we had lots going. Harvard has different partnerships and whatnot. And I was the executive director of the Harvard AIDS Institute, and each year we gave out an award for the leadership award. Who was the biggest leader that year internationally for AIDS? And pretty much in the core faculty would vote. Every year, Elizabeth Glaser would win the award. But then I was the executive director, so I was given the task to go ask her, the only requirement we wanted somebody to show up. And she's like, I don't like awards. I don't accept awards. She didn't tell me to shove it, but she's basically laughed and said, there's too much to do than have awards and things. So we'd never told people that she won the award because we didn't want to tell people that somebody refused the award. So we always went to the next person, which were some leaders, Arthur Ashe or many other great leaders that won the award. But I got to know Elizabeth pretty well because each year I'd check with her and I'd say, the other thing, Elizabeth, you really have to go international with your foundation. She goes, well, there's nothing for kids nationally. I'll eventually go internationally. I said, but this is where most of the infections are now, and the need. And now that we have a drug that was helping with AZT, I kept making her promise that you're going to go international. I can help do this. So I volunteered for her foundation for many years, as all of us did. And she'd raise money, her and the two other co-founders, and give it away every year. As much, they go out of business every year to give it for research for pediatric AIDS. And it was...
Sorry, the Glazer Foundation was a Track 1 partner. This was...
Not yet.
Not yet. Okay, sorry, you're getting there.
Yeah. So they we realized at the Glazer Foundation that the treatment was expensive. This is IV AZT to the mother right before you're giving birth, then to the baby, and it was, $1,500, $2,000 to prevent an infection. Great, you prevent an infection, but that's still expensive, and it's still intravenous, and it's really hard to realize it happening in a poor clinic setting in Africa or the Caribbean. So it wasn't being rolled out, even though, and I told Elizabeth, I said, look, we have a solution, it's working, it at least prevents, majority of the infections to the baby. Well, yeah, but how are we going to roll that out? It's too much. Yeah, I can't, there's too much. I'm here in the States, there's too much going on. Then Laura Gay and the folks working in Uganda showed that if you just gave the pill, AZT, to the mother and gave some to the baby orally, just, like one dose, if you can't give more, and one dose to the baby, you still prevented the same amount of infection. So it's kind of like then, okay, there's no excuse now. This is very simple. And the patient comes in, it could come in labor, you could treat and prevent infection. So then Elizabeth Glazer said, you're right, okay, we're going to do it. We need some money. The Gates Foundation gave them $1 million. Said, start a program, get AZT out there. Laura Gay is she's now still one of the scientific directors of Elizabeth Glazer Foundation. She's working in Uganda. Said, yeah, we can do that in Uganda. Yeah, we can do that. So they started getting partners that were in South Africa, Uganda, and giving AZT. Let's set up in the, people coming in to deliver, let's start getting them AZT and testing them quickly. And even if you don't have time to test them, it's just one dose or something. So long story short, they started setting up. And then PEPFAR is announced. So they're an organization that's already taking care of people, although they're just giving one drug, and it's very focused on mother to child transmission, but they fit the criteria. They've been doing it for 3 years and been doing it more in 3 places. So when this came out, December 1st, 1993, the actual Track 1 announcement for grants, at the end of the year after Bush announced PEPFAR, they said, will you come help us? We're going to go for this. Elizabeth Glazer's, their headquarters is always in Santa Monica, but they had their bigger headquarters in Washington now because they were starting to become international. And they said, well, I can give you a week. I'll come down and help you, because I did care, not just mother to child transmission. I took care of AIDS patients and was setting up in Botswana we took care of AIDS patients and et cetera. So you have to come help us. And I said, I'll give you a week just to volunteer. And then I checked with the Harvard people and the medical school. They all said, no, we're not going for it. It's too crazy. We're not going for it. Which they were lying, but they knew they were going for it, but they were acting like, no, we're not going for it. And so I went down to Washington was helping Elizabeth Glaser, we started putting this big grant together because we only had until December 31st. And this is a group that, hadn't done a big grant like this, but also had not really set up bigger programs. And some people were thinking it was wrong, we're not going to make it, or how are we going to do this? And then Phyllis Conkey called me from Boston and said, what are you doing? I said, well, I'm down here working on the track 1 with Elizabeth Glaser. She goes, we have to go for this. Harvard School of Public Health, not the medical school. Harvard School of Public Health. We can't show our faces in Tanzania and Senegal and Botswana, and we won't be able to, if we don't go for it. We may not get it, probably won't, but we won't be able to show our faces if we don't do it. And I realized she was right. And I said, okay, I'm here. I can work at night on the Harvard one, but I work during the day with these folks. What's the medical school doing? Oh, they say they're not going for it. Are you sure? Because we don't want to, we'll be competing against ourselves, and neither one of us would probably get it, but 2 Harvard applications. Long story short, there were 2 Harvard applications, but the School of Public Health got the application, led by a veterinary virologist, not an MD, which made Larry Summers, the president of Harvard, crazy. That's a longer story. But so he tried to block the grant. But and Elizabeth Glaser got the grant also. So now I'm on 2 of the 4. And I knew my life was going to be different, because then again, money's not the issue. But then there's Elizabeth Glaser was 5 countries. And then Harvard, I was the Botswana director, and Wafai Fauzi was the Tanzania director, and Phyllis was the Nigeria director. So then there's 6 countries that I'd be doing PEPFAR in, in a matter of, found out overnight, basically. And, so I actually went to the dean at the time, and Barry Bloom was the next dean at Harvard, and said, I'm going to have to take a leave of absence and probably resign, because the really busy one will be 5 countries, Elizabeth Glaser, how to do this. I was the PI for the grant, so I said, I'm going to have to resign. And he said, wait, close the door. When somebody says, wait, come in here and close the door, that something interesting is they're going to say something interesting that's they don't want somebody else to hear. But he goes, you don't have to resign. I said, no, but I know the rules at Harvard. You can take a leave of absence for up to 2 years, but then you have to decide you can't be on the faculty and you can't have another job or be on somebody else's faculty. So you got 2 years to take a leave of absence. He said, no. Harvard is, it's a private institution. Those are not laws. Those are, regulations. And he went like this. I said, okay, Barry, if you put it in writing that I can keep working on the Botswana part of PEPFAR, but I'm going to be probably moving and working on Elizabeth Glaser. And we ended up moving to Los Angeles to do that. But I think basically the dean of the school did not want to give up a big grant. But at the same time, it was a great partnership in Botswana, and it helped. And on the positive side, it was the right thing to do, but they had to sort of go against regulations. Luckily, as Harvard's a private place. So that's how I got into PEPFAR, I guess, and both Track 1 partners.
So you're like neck deep in PEPFAR pretty much from the get-go. What did that scale up look like? And if you want to use Botswana as an example, because you've told us about, all of the work that you guys, that you've already done there, building this clinic, training people, establishing this training program. from that point, what did the PEPFAR-induced scale-up look like in Botswana?
Well, in Botswana, it was, I guess we'd already started with 100 million to create HAP, free drugs from Merck, which they didn't want to talk about, but that was part of the partnership. And so it was not a huge, compared to the other PEPFAR grants, it wasn't a huge grant. It sort of filled in the parts that were needed, like to make the training program become nationalized and sort of continue on. And actually, training we created what's called master trainers, so that these experts, as we said, they're real experts in treatment, were in Botswana, from Botswana, clinicians there. So they became the mentors, whether at a distance or sort of adopted sites. So we wanted treatment in every clinic. So there's 230 plus clinics around the country. We wanted everybody to have the same access. Walk into a clinic, you could be treated just like you'd be treated for anything else. And so every master trainer kind of adopted sites and said, I'm with you. Call me if you need something, or I'll come if you need me to actually come. But it's pretty spread out in Botswana. So a lot of times it's, call me and I'm on call for you. And we'll do specialty training and other things. So the training program became sort of much more elaborate, I guess, and involved mentors and mentees. And then the other parts of testing, the parts of supply chain management, the parts of monitoring and evaluation. So we set up with the PEPFAR money, we'd be able to set up a monitoring and evaluation system. And we actually had an electronic medical record that we had homegrown ourselves with the pre-PEPFAR time with Merck, Gates, and HAP, where most people are not on an electronic medical record in Africa, in fact, are not. But we were able to, anybody that was on treatment or knew that was HIV positive and might then need treatment, got into an electronic medical record. So then those 230 plus clinics knew how much drug they're going to need to bring in. So on a pull system, rather than just somebody predicting in the central pharmacy, I guess they need some drugs over there. We don't really know how many patients they have, but send them some drug. So they may not, if you interrupt your drug treatment with AIDS, that's bad. The virus can become resistant to the drugs, and then the drugs don't work. So you don't want interruption in the supply chain. And so for AIDS patients in Botswana, there is no interruption in supply chain. For other things like we're working on now for cancer, there can be interruptions of cancer drugs because they're not part of the electronic supply chain system. Where are the patients? What drugs are they on? How much drugs are we going to need to send out to those 230 plus clinics? So we were able to put all that in place with PEPFAR and really make it a national effort.
Mm-hmm. Got to ask you a couple of, wrapping up questions
Sure.
in the last 10 minutes
Did
here.
we get enough in on about PEPFAR?
I mean, I think we could talk to you for hours and hours, but I want to know, how do you think that PEPFAR influenced your thinking about public health and global health? Of course, you're working more on cancer now. How did your lengthy experience working with HIV/AIDS treatment and PEPFAR more specifically affect how you've thought about the work you're doing now?
Yeah. I guess it drives home the importance of partnerships, that I mean, in a working true partnership, people can be trusted. Both sides of the partnership, people work towards a common goal. The other part of the partnership, though, if you're working in somebody else's country, they're really in charge of the partnership. You're a minority stakeholder or whatever. You're 49% of the 50-50, and they're 51%, because it's their country and it's their setting. They both know the place better, almost every time, and it's their country to decide what to do. So the partnership, if an outside partner comes in with that, not just knowledge, but acts, walks the walk like that, then the partnership flourishes and continues on. As I said, for our Senegal partnerships, that's continued on, and Botswana's continued on, and same's happened in Tanzania with the Harvard partner there, or other partnerships that work. The outsider's not in charge, but it is a partnership. The other is just the power of setting up public health programs that have been thought through from the beginning and are willing to invest in the nuts and bolts of doing that. As Paul Farmer would say, the stuff, that's needed. There's a lot of stuff that's needed. There's people, training, and all the other stuff. Not just equipment, but the things that make a program work. So like the example I said that really makes it work in Botswana over the long run is setting up the monitoring, the evaluation system, the electronic medical records that then can help the central pharmacy know what to do. And so the whole place operates as everybody's in the project together. I remember talking to cleaners that were cleaning clinics at the beginning when we were doing our training programs, and many times they would say, I'm so proud of being working in this clinic because I'm part of the solution. I'm part of saving our country and helping people. Again, every family was affected, so they really felt like they could do something. Probably their own families, every family was affected. But the idea that the cleaner is as much part of the system as the doctor or the nurse or the pharmacist, or the head of the Ministry of Health, or et cetera. I think the power of a system that does that, and it happens not just in Botswana, but those are my examples of when it happens in Senegal or Botswana. I guess that's what we're trying to approach with cancer, because again, the inequity with cancer is like what HIV used to be. Now treatment is very widespread in Africa. It doesn't mean AIDS is going away, obviously, but the treatment works better than we thought in terms of if you're on treatment, you don't spread the virus. It's like a vaccine in the sense that, the spreading the virus is reduced also. But cancer is really the death sentence that HIV used to be. So using those same principles to approach cancer, cancer's a more diverse disease and has more specialty treatments, but still, the more you realize you're taking care of cancer patients or someone who might get cancer, so they need to be screened or have cancer detected early. The more you realize about cancer as a clinician, the better your patients are going to do. So I think we're in the same boat, as it were, that we can respond to cancer in Africa with that type of partnerships that PEPFAR helps make possible, or the cancer PEPFAR could help make possible, but the country's in charge, and it's system-wide. It doesn't just involve one specialty or whatever. That'll help with cancer and turn it around to where it's not the death sentence that it is now in Africa.
Well, I want to get you out of here on time,
Yep.
but one last question, which is, do you have anything you want to add?
No, I'm really glad you all are documenting and taking the history of PEPFAR and how you're doing it.
You can go ahead and ask.
So, thank you so much. I just wanted to find out, with all this experience, 40 years of experience in Africa, global health, HIV, now cancer, and I reckon you're a professor in the institute. You have medical doctors and different health professionals that you're training. I mean, how are you able to bring all that wealth of experience to make sure that you're training MDs, health professionals that are really going to be aware that being an MD, you also need like the public health lens, and how that has really helped you to become the professional, the expert, and the physician that you have become now? Thanks.
Yeah, I think we have to learn from HIV in that sense. With cancer, we're at the beginning of trying to do that, and we're still at the place where money is a rate-limiting step. We can make a small amount of money go really far, like we did with HIV, but it's really a rate-limiting step with cancer. So right now we're trying to demonstrate that cancer can be dealt with if we train the people that are already seeing cancer patients. They may or may not know they're seeing cancer patients, or they are seeing them and they're not trained to be oncologists, but they can be. Sort of training on the job. And also we're showing that a little bit of money can go a long way in that program, in programs in general, public health programs. I guess that's where we're at right now. I think it's more of a mindset, because again, I'm not trained in public health, but you end up doing it. And when you see the power of setting up programs.
Well, thank you so
Yeah,
much.
I didn't realize how long we've taken.